Hello and welcome here at another EAO Just Ask, your monthly live appointment with a leading expert in implant dentistry. My name is Gerrit Heijkoop and I'm the host of this EAO channel, and in this live video session we're going to try to answer any question you might have about the topic of handling soft tissue defects, specifically in the aesthetic zone. And to do so, I'm very happy and honored to be joined live from Porto in Portugal, where it's beautiful weather. Paulo Carvalho. Paulo, good evening.
Good evening, Gerrit.
Yeah, we see the bright sunshine on your face. It must be wonderful in Portugal. You're combining a unique expertise. You're a very well-known clinician, and you do a lot of clinical work in your private practice in Porto. You lecture a lot, but you combine both extensive knowledge in the prosthodontic field and in the periodontic field, and that makes you the unique expert for the topic we talk about today, handling with these soft tissue defects, especially around implants. And like always, I've already asked our participants who are now with us live in the chat, let's create some community here online tonight. If you're watching this right now, please sound off in the chat who you are and where you are joining us from, like always. And we already saw that Emmanuel here was very early joining from Athens. Ferruccio Torcello is joining us from Italy. Tom Canning from Dublin. Christopher Apokist from Sweden. Good to see you again, Christopher. Wim Slot from Groningen, also starting to become a regular participant in the EAO Just Ask. And as you can see, I have the live chat in my iSet site. So if you have any questions during the next hour or 75 minutes, please make sure you send it in and I will relay your question to Paulo. Paulo, before we start, did you know it's a very special day today, May 3rd, 2021. It's officially the first World Osseointegration Day. If you've never heard of that before, well, that's correct. It's the first today.
It's an amazing landmark for us, Gerrit.
It is, and it's an honor to have our EAO Just Ask on that day today. It's a new global event honoring Per Ingvar Branemark, who is the scientist who coined the term osseointegration. He was born on May 3rd, and from now on, May 3rd will be World Osseointegration Day. And I invite everyone after joining this EAO Just Ask live to check out eao.org/osseoday or the link on the social media channels of the EAO, because there you find a beautiful lecture by Professor Thomas Albrechtsson about how it all started with osseointegration. Well, that's history. Let's talk about today and the future, Paulo. When we talk about dealing with soft tissue defects in the aesthetic zone, to kind of set the scene tonight, what type of defects are we looking at?
Oh, Gerrit, first of all, let me thank you for the amazing introduction you made of me, myself as a clinician. I'm really honored to be here by EAO invitation. And you described me in a way that it makes me even more nervous to be on this stage, if we might call it a stage. But I'm here, heart open to all these colleagues that took the time to join us in this evening, and we will be here to a great discussion, I guess, and I'll be free to all the questions that may arise. So yes, this subject can be really wide in terms of the amount of situations, different situations we might face in our clinical day. Every time we extract a tooth, actually, we will face some ridge resorption. It can be more or less, but we will always face some hard and soft tissue resorption that will lead us to a situation in which we will always have some volume missing for the final tooth, for our final prosthetics. So in the aesthetic zone, especially nowadays that patients are getting more and more demanding. They demand more and more that our prosthetic restorations really appear like natural teeth. So we really need to struggle. Of course, when we have a single tooth missing is not quite the same when having a multiple teeth missing. But I will say that it can go from a simple situation of a single tooth missing where we have enough bone. Although the ridge resorts, we still have enough bone to place our implant, but we don't have enough soft tissue to shape around our future restoration. Or in more dramatic situations when we have already an implant placed and it might have a dehiscence, and we will have to recover all the tissue that was lost around an implant, extracting it or not, but for sure it will be the ultimate challenge to deal with, because it's the most difficult situations to face when it comes to undergoing soft tissue dehiscences on the aesthetic zone.
Exactly, and these are cases that might walk into all of our clinics, and we have to deal with it. And today we're not so much talking about preventing, well, maybe later on as well, but first we start from the point you are confronted with a case or with a patient who is struggling with a soft tissue defect in the aesthetic zone. Now, as I said in my introduction, you combine two unique areas of expertise, the pink and the white, both unified in you. What would you say is the biggest contribution to resolving these defects?
Well, I think you just touched the central point in here, because very, very quickly I realized when doing my soft tissue graftings at the beginning that I really needed a specific answer right away from the prosthetic point of view to shape that soft tissue. And it is very common that nowadays that interaction between the perio and the prostho is quite neglected, because a lot of times we see soft tissue surgery to be performed without a provisional that is set up accordingly to the surgery in the same day of the surgery. Sometimes we see the teams completely divided and separated. So the surgeon is completely separated from the prosthodontist. And what will happen is that the result is not going to be the same as when we have a joint work of perio and prostho. I'm not saying that the job has to be done by the same clinician. It will be maybe the ideal world to have the same clinician doing both parts of the job like I do, but of course it can be done by separate clinicians, but both clinicians are present in the diagnosis, in the planning. Both clinicians will probably be at the surgery, and then the prosthodontist is going to be leading the work to the final restoration. But when we see the joint work of perio and prostho, we realize that is not quite effective if I do an amazing soft tissue graft and I don't have the idea of what the prosthetics is going to do afterwards. And the same way as the prosthodontist is going to be very limited if he receives the patient already with the surgery done and no provisional was made at the time of the surgery, no scalloping was made from the day zero, and the potential is amazing when we join both together, because each step of the treatment, each step of the surgery, and sometimes we have different surgical steps. Sometimes we have 2 or 3 surgeries for the same patient in the aesthetic zone for the same case. And each step will require, from the prosthodontic point of view, a different answer at a different level.
Okay, so in the meantime, I see more people dropping in. Good evening to all. It's Jaco from the Netherlands as well, Ahmed from Morocco, Mario from an Italian from Madrid, he writes, Mohammed from Iraq, Ruari is also here, Helene Francisco is joining us, also from Portugal. Hi, Helena. And Julia is also joining from Germany. We are talking to Paulo Carvalho about managing soft tissue defects in the aesthetic zone. And Paulo, you say the key is that the prosthetic clinician and the periodontist or the surgeon work together. And if I listen to you carefully in these last few minutes, would you say where's the key point where they should unite? Is that in that provisional solution right after surgery, or?
Yes, indeed. I would say, like I say a lot to my colleagues, that even before starting with the blade, we have to think about the provisionals. If you allow me, I'll share my screen, and I can show a perfect example of it. We can see how in every areas where I diagnose, I realize I have some soft tissue missing. I have to predetermine my provisionals according to what I desire to be my final rehabilitation. So I have to set the new cervical margins of my final teeth, my final implant prosthodontist, whether on implants, whether on teeth. You can see how in an implant site, I'm predetermining the height of the teeth, the new cervical margin, the amount of soft tissue I propose myself to regenerate. And you can see even in a tooth, in the lateral incisor 22, you can see how I'm determining the new, like a new cemento-enamel junction to receive the surgery. So the surgery is done already to the ideal emergence profile for the final prosthetics. And it's very important to guide the healing of these soft tissues with these provisionals from the first part of the jaw, from the day zero. And of course, we have to predetermine as well the potential, the regenerative potential of each case. So we know already that we want our implants to be, according to Fernando Vizcaya, the implant will be 3 to 4 millimeters apically to the new desired margin, and we want our implants to have 2 millimeters of bone around it, and we can diagnose how much bone we have, how much soft tissue we have, and we know the principles that allow us to augment the hard and soft tissue and the soft tissues around it. And if it is possible, I go to the surgery planning exactly like this. When we do bone augmentation, we want to augment the bone, and we advance the soft tissue so much that we leave them completely in excess coronally, and we pretty much don't care about the shape of those soft tissues because they will be shaped later in later stages. But when we are only augmenting soft tissue, it's completely different game. It's a completely different mindset. We really need to have in those in that transition zone, which are the first 3 to 4 millimeters of soft tissue in the transition zone, they need to be carefully shaped from the very first beginning. And that has to be said by our provisionals and our joint work of perio and prostho together in the same moment. And as the soft tissue maturation is going to happen after this, the response of the emergence profile of these provisionals has to be different from in each stage. So I pretty much think that every time we are only taking care of the soft tissues from the surgical point of view or only from the prosthetic point of view, I will always see that as limited. And nowadays, for me, it's quite obvious that these joint disciplines, which for me is already a different discipline, perio-prostho, it's quite obvious that it's a game changing right nowadays.
Exactly. Well, you're definitely very passionate about that and very clear. I want to clarify one specific thing. You say specifically in that early phase, it's very important that the professional is there. Yeah. Let's flip that around. How would I recognize in the clinic if something went wrong in the early phase? What happens if I didn't?
Well, actually, I can understand, or at least I should diagnose at the beginning that regenerative potential. And if it is quite possible, I will advance my tissues in the surgery. And a lot of times, me, myself, I'm during the surgery, intraoperatively, I'm understanding how my soft tissues that I'm augmenting, how is it dealing with the subgingival contour of my provisionals. So I can understand sometimes that my provisional contour is compressing too much the tissues and will not allow me to augment that much. Or sometimes I understand that my provisionals are under contoured and they will not support the tissue at the position I want. So you can see these two situations need my answer right away in that moment. So if I'm doing as a surgeon alone without any knowledge from the prosthetic point of view, I will not be able to make this option during the surgery. But if I have the prosthodontist with me, we can very easily adapt at the same moment of surgery. So for me, that is quite unthinkable nowadays not to join the two parts together.
Exactly. And you would say it's not even important in the diagnosis, the planning, but even during surgery, you want
during
both
surgery.
expertises in the room and be able to
Yeah,
do real-time augmentation if needed.
for sure.
Interesting. In the meantime, Paulo, our room is filling up. So, good evening to everyone. Welcome to this EAO Just Ask. And as the title denotes, we are live. The chat is live. I'm looking at it. Hello, says Sem from Albania. Miguel, good evening. Peter van der Schoor from the Netherlands. Welcome, Peter. And also Brunilda is joining us from Albania. If you have a question about this very passionate point made by Paulo, it should always be a perio-prostho joint expertise who work together. I can imagine that raises some questions, some challenges, or you want that clarified. Please write your questions in the chat and I can relay them on your behalf. Make the most of the fact that we are live, because if you don't ask, you never know. Now, Paulo, you say it's very important that in the beginning that you diagnose correctly the potential. Can you take
Mhm.
us along some different type of challenges that we might encounter and what that means for our the different type of defects from simple to complex?
Yes, I think that the most simple situation is in a single missing tooth, where after the extraction, we of course might have some horizontal depression of the heel ridge, but still the adjacent teeth maintain the interproximal bone peak. So if the interproximal bone peak is still intact, the papilla will not be a problem. It might not be there at the beginning of the case, but as we augment the horizontal soft tissues by grafting or by moving the tissue from palatal to buccal, if we set up the contact point of our restoration at the correct level, we know for sure that the papilla is going to appear sooner or later. The main problem is when we are dealing with multiple teeth, because of course in multiple teeth we will face the absence of the interproximal bone peak. So to have in some situations some, let's say, an aesthetic balance between the gingival contour and the white contour of our prosthetics is not quite easy, as when we have multiple teeth missing, because we will have two square teeth because of the absence of the papilla. It can be a small absence, or it can be a big absence. It can combine horizontal and also vertical defects. So in those cases, I will say it is when the perio and prostho has really to be brought together in different stages in order to accomplish a very good result.
Yeah, I believe, and now we give away that we always have a little pre-chat before these Just Ask. You told me you have a case which really shows all these different aspects in this specific situation. I think it's interesting for our audience to have a look at that.
Yeah, I can share a case in order to illustrate what we are talking about. We can see, for example, this case is actually a very challenging case, and it might be controversial. If you like that, do you like controversial stuff?
I think it's better, because then at least we trigger our audience to start a debate with you or challenge
Okay,
you. So again, audience, please use the chat, listen carefully, and see
Let's trigger
if this
them.
leads to
So
any questions. Show me.
we can see an aesthetic case in the frontal upper arch, where we see failing teeth on 13, 21, and 22. Actually, there were already failing implants in the past in this young lady. You can see the area of 11 and 12 with missing teeth. And you have a vertical, not only horizontal, but also vertical bone dehiscence. And nowadays, this patient is already failing the teeth that were used to supply a fixed prosthodontics for this patient after the failing implant. So again, I'm dealing with a failing teeth, and now in even a larger area. So what I did was immediate implants at the sides of the teeth. So immediate implants because of those failing teeth, on implants on 13, 21, and 22, and only soft tissue augmentation at the pontic sites on 21 and on 12 and 11, because it was not that predictable to do vertical augmentation. Well, we all know how difficult and how sometimes unpredictable it can be a vertical augmentation. So if I had enough bone to place my implants and I had at the socket sides, I prefer to put my implants at the socket site and deal with the lost contour of the ridge vertically and horizontally only with soft tissue. And you can see again how we have two adjacent teeth missing, and already the papilla between 11 and 12 is completely away. And what we do here is with our grafting, and there was two different grafts that were made in two different times. First a tunneled graft and then a free gingival graft to create a deepening of the vestibulum. Sometimes only a single graft can be enough, and the density of the grafts may create that deepening of the vestibulum. In that case, it didn't happen. So we did the second graft. And now you can see what I always like to do in those cases, which is create excess of tissue coronally. So we graft the most coronal we can, where we have the missing height of papilla, and we want to then recreate the ideal soft tissue emergence by shaping that excess of tissue. It's almost by subtraction. It's not quite a graft of the papilla. We graft an area, a coronal area, in order to have excess of soft tissue. You can see here, you have, when you take a look at the desired emergence profiles, you can see that we have already excess of tissue that allows me to reshape this newly formed soft tissue as I want. So you have already the tip of the papilla between 11 and 12. So you always need to, and the contour your provisionals, graft coronally, and then you are able to condition, do the proper prosthetic soft tissue management by starting to compress that excess of the soft tissue by adding material or by doing a new set of provisionals in an indirect approach. But the idea is to reshape the soft tissues. In this papilla will arise only because we created an excess of tissue. That's my point of view for multiple teeth. So this is the transition I do. So in the implant side, we go from an under-contoured subgingival contour to a more convex one. And in the pontic sides, of course, it's even more obvious what we have to do. So you have in both different sides. At the left hand, you have the situation at the beginning of the surgery, and at the right hand side of both situations, you have the how the provisional was reshaped after soft tissue maturation. And you can see how the implants are placed in the previous sockets where we have bone, and how we dealt with the loss of not only soft tissue but also hard tissue. And you can see how we can compensate such a vertical distance to the bone, which will not be a problem because it is a pontic site. There is no communication between the outside and the inside. So that soft tissue will be maintained by the contour of our prosthetics. And you can see the finalization of the case, the ending of the case, with permission by the patient to show the face. And I think this is, Gerrit, a case that perfectly illustrates how much challenging it can be multiple teeth in the aesthetic zone when it comes to implants and failing implants or teeth.
Exactly, and it ends with a beautiful smile. Now, as writing along, because you were on a roll telling us about this case, there's 3 questions I wrote down, and I invite my live audience to also commit their questions if they have. First thing, just to clarify, I heard you say very quickly, you say the vertical bone augmentation is very unpredictable, so I rather choose for a soft tissue augmentation. Is that a general thing and rule that you go by? If possible, if feasible, rather go for soft tissue augmentation than the bone augmentation?
Well, the vertical augmentation in this case was possible. I will not say predictable, because I can say let's say that I'm saying unpredictable also in my hands. Of course, we have amazing clinicians. We have amazing people like Sven Urban, Fuad Khoury, a lot of brilliant clinicians all over the world who brought us great techniques that allows us to do it. But yes, it's true that it's not for everybody. It's not for all the clinicians. And we have to be aware that not all clinicians are able to do such type of procedures. And yes, even clinicians who learn the techniques and do it quite often, and I do it. I learned it. I do it quite often, and I don't have the same predictability as in soft tissue surgery. So
Exactly.
in one hand, I have the patient who can be presented with a much simpler, straightforward treatment with less surgeries and less invasive surgeries. And on the other hand, I also have to acknowledge that even though I'm able to do such type of bone augmentations, I know from my own experience and from experience of a lot of colleagues that say the same. It's a very complex, very technique sensitive procedure, that the outcome is not always the same when compared to the soft tissues, in which even after the maturation of the graft is done, the soft tissues can only get better and better with time. We see it quite often. And when we deal with bone augmentation, especially the vertical augmentations, it is quite, let's say, often that colleagues share with each other that they struggle to keep that augmented bone during time, and it's not quite the same as keeping the soft tissues that were grafted in the past. So that's what makes me, in those cases, if I have enough bone to place my implants, I try to avoid the bone augmentation. Not only because of the efforts. Not only because of the efforts, but also because
appreciate we have a 2-second delay. We should start to work with that. But I was going to say, I really appreciate the honesty, because I think we're in front of a global audience and not everybody is a rock star in surgery and bone augmentation, right? So this is indeed a great alternative to learn from.
Mm-hmm.
Second question I wrote down. You say, I choose to have some excess tissue coronally and then I reshape, which I think is pretty smart. But then you talk about the bone augmentation as an invasive protocol also from the patient side. I was wondering, what does this treatment look like from a patient perspective? What are the timings? Do I have to come back? Do you reshape it right away? What does that protocol look like?
Yeah, it's from the patient point of view, it's much faster, because when we consider it's only one soft tissue surgery, which is the general case, after 3 months of the soft tissue surgery in the implant surgery, because it's in the same surgery, we can start reshaping the newly formed soft tissues with the provisional. So in 3 months time, they have already started the final restoration. And then after reshaping that soft tissue, only 1-2 sessions are enough. Let's say that in a period of 6 months, that case can be done. Of course, it depends on how much soft tissue has been rebuilt. It depends also in the response of the soft tissue to the prosthesis, because sometimes we reshape the prosthesis in the tissue is already conditioned, completely sealed, which we see already the adherence to the new connective tissue, and sometimes we need to more steps than that. But when we compare to bone augmentation, probably the bone augmentation, depending on the technique, whether it is fully autologous or it is with biomaterials, it can go from 4 to 9 months healing time of period, and then the implants placed, and then 3 more months, and then for sure it will be more than a year. So it's quite different in much more interventions or surgeries.
Exactly. And that's why you say, if it's possible. Of course, it's not always possible, but if possible, I try to solve it with the soft tissue.
Sure.
And then the last question, and then I go to Ruari Konana's question, which I've seen in the chat, Ruari. But just a thing I wrote down when you started the case, you said this might be quite controversial. I might have missed it, but can you allude to what was the controversial part in this case?
The controversial part is because of building or solving such a vertical bone defect only with soft tissue, because a lot of people will ask themselves, how will that soft tissue be stable over time if I'm only doing soft tissue augmentation? Because people tend to think that the soft tissue will always follow the bone level. And it is true if we are dealing with hillsides with no soft tissue grafting intervention. But when we graft soft tissues, we create the same environment like we have in the tuberosity, where we have a very thick, dense soft tissue, and that for sure is quite much more far away from the bone as in other regions. So we create dense soft tissue grafts to create this excess of tissue. And because of the histology of this type of soft tissues, it can be maintained that far away from the bone, especially because it's a pontic site. So if I put an implant at the bone level in that region, probably the compression of the abutments at that deepness, or maybe the peri-implant environment will want to prevent contamination. The soft tissues might have recession with time. Yes, other people will say, yeah, but if I under contour my abutment a lot, and with the fully customized abutments, we can have an implant really deep, and the abutment goes really, 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 really skinny, and then it opens at the emergence profile. Yes, that's also possible, but that's not predictable. So what is predictable is at the pontic site, where there is no connection between the outside and the inside. Yes, I can have only with soft tissue augmentation, and I can completely regenerate that site only with soft tissue, even though the bone is far away, because I have interproximal regenerative potential. So it's something that I can use a lot of examples from my clinical practice to support it.
Exactly, very clear. Thank you very much. Let's go to some audience questions, because Mike has also submitted questions. But as I said, I'm starting with Ruari Kunane's question. The question is, do you ever use mixed epithelial connective tissue grafts? We're into the grafting.
I don't see it as a very useful thing to do, because, well, when we really graft epithelium, we want keratinized tissue. And in the aesthetic zone, the first thing is that there is not that aesthetic. For example, in the case of this patient, the second graft was with, actually it was not with epithelium. I depithelialized the graft, but as it was dense and I have the lamina propria, still it had the outcome of a very whitish graft, but it was a patient with a low smile line, and it was not a problem. But in situations like this, if to have the best type of soft tissue augmentation, to have the most volume augmented, I need to use submerged graft, because I have to advance the tissues. I know that when I submerge a graft of an advanced soft tissue by tunneling or by coronal advanced grafts, I will have more augmentation. So I will have to use depithelialized grafts. It can be useful if you are grafting in a socket preservation. You can use a partially depithelialized graft, where the epithelialized part of the graft will be the entrance of the socket, and it will be sealing the socket. That can be useful, because you will have a graft that can be exposed at that part of the socket. But for my experience, when I use a fully depithelialized graft for those situations, and I tunnel the graft partially buccally and partially palatally, if 2/3 of the graft are completely submerged, that exposed part at the entrance of the socket will not be a problem, because it will revascularize by the surrounding areas, and the aesthetic outcome is much better than the epithelialized exposed part when we choose a graft like that. That's why I'm saying that it's not quite useful nowadays in my hands.
Well, thank you very much. And Ruari, I hope that answers your question. If you're just joining us, we're talking to Paulo Carvalho from Porto in Portugal about dealing with soft tissue defects. Mike Jordan is also making use of the fact that we are live. Here's sending in the following question. Does the scar tissue formed as a result of the secondary healing around implants have the same quality as the keratinized tissue to seal around the abutments?
I'm not sure I understood the question. The scar tissue.
So the scar tissue, which is formed as a result of the secondary healing around implants, he says, does it have the same quality as the keratinized tissue to seal around the abutments? That's what the question reads. If it's not clear, that's as clear as I can read it. So Mike, then you have to come in and write it a bit more.
It's quite confusing, but I think I understand that if we have a secondary healing, maybe you're saying a delayed approach in placing implants to wait for the healing after the extraction and then deal with the soft tissue that covers the extraction site, and that'll deal with it. Yes, it can be predictable. It can be less risky than some immediate implants for sure. But for me, the potential of doing immediate implants, as in the case I just presented, the elements 13, 21, and 22, only by doing immediate implants and immediate provisionalization, I just supported the original soft tissue, the original architecture of the socket, and it helped me to maintain that soft tissue all the way along to the final restoration without having to do extra procedures to augment the soft tissues. I had to focus myself on the defect on the pontic area, and it was more than enough. So having that option to do the immediate implants allowed me to solve that part of the job in a much more effective and simpler way. I'm not sure if it was the question, but yes, every situation in which we have scar tissue, the scar tissue, yes, it's a dense connective tissue, and it can be used to seal around the implants, around our abutments, and prevent contamination around the implants. Yes, but we have to understand where comes that soft tissue, because leaving by secondary healing already placed implants might not be good because of the initial contamination of the site. I'm not sure if it was the question.
Exactly. Well, Mike, I hope this is useful for you. If not, I'll see him jump on the chat again. Paulo, we talked about the different challenges where these soft defects might occur. We started with the single tooth situation. We had this extensive case with the multiple tooth. Let's move, since we are with a crowd of implantologists tonight, to the situation where we discover a soft tissue defect on an already placed implant. Then what?
Yeah, I think it can be the ultimate challenge, because first, I would like to point out that when we have already placed implants, if we have a defect around already placed implants, well, we might have a periimplantitis going on, so we might be dealing with an infection. And if it is an infection going on, we see suppuration. We have not only bone defect, but we see suppuration, edema, swelling, bleeding. So I have to deal with the infection. I have to treat the infection. Sometimes in a resective way, sometimes first with medication, but first I have to treat the infection. And once the infection is gone, probably I will expect recession around the implants, the recession of the tissue, and we'll have to, by that time, assess what type of soft tissue do you have to have, what regenerative potential I have, and if it's possible if in the aesthetic zone, if it is possible to only cover and treat the adhesions around the implant without extracting the implant, I prefer it. Just as in the same case as in the last case, I see it from the patient's point of view. Yes, for me, of course, it will be easy to extract the implant, wait for the healing, and in a delayed stage, I will re-enter, put my implant, do the bone augmentation, do soft tissue augmentation, and with the implant at the correct 3D position, of course, I will reach a better final outcome, much more easier. But I have to understand that for the patient, that will cost multiple surgeries, multiple healing time, and for the patient, they have to jump from a fixed tooth and probably spend a lot of time with a removable tooth or something like that, and it will it's quite impactful in their daily life. So
Yeah, yeah.
if it's
So
possible
we
for
go
me
for
to
the
follow
hard
with
way.
soft
We're
tissue,
going to save the implant, but still get rid of the defect, which is an aesthetic failure, right? This is a problem if we can see. So
yeah.
what can we do?
Yeah, most of the times the problem is that the soft tissue occurs because of or a badly placed implant in terms of position. When I say badly, of course, it happens to all of us. I've been facing those problems with implants placed by my own, of course. Whether it can be an implant placed too buccal, or maybe the implant was too large, too thick, or the abutment was not the right one, and it created a compression of the buccal soft tissue, or maybe there was an adhesions during the surgery and it healed without infection, but because of the adhesions of the flap, it can create a recession on the tissue. And so we need to understand if it's possible.
No.
Is it?
Whoa. Yeah. Just let's try to ignore. Our outro is starting. Not sure why that is, but there it is, gone. Yes. So back to the implant.
So back to the implant. We have to understand if it's possible to create thicker tissues buccally to the implant in order to cover the implants. As in teeth, if we have interproximal attachment, it will be possible to advance the tissues and to cover our adhesions. So that's why we see most of the publications in the literature are about single implants in the aesthetic zone, which means that we have adjacent teeth that are keeping the interproximal bone peaks, and we will take advantage of those interproximal attachments in order to advance our soft tissues, our margin, whether it is with the coronal advanced flap or tunneling technique. We are able to cover the adhesions. But we have to keep in mind that those surgeries are much more complex than when we are augmenting soft tissues around an implant that is correctly placed, because we are dealing with thinner tissues, we are dealing with less space in an horizontal perspective, because when we have an implant completely palatal or at the correct deepness, we have much thicker tissues. It's much more easier to separate the tissues in order to create a bilaminar soft tissue grafting, as we like to do. So the situation is much more complex.
Exactly. I'll hold my question, which I just had, because our audience is submitting questions as well, and they always go first. Let me go back to Ruari Konane first. What are your thoughts on surgical papilla regeneration between an implant and a natural tooth? As you just alluded to, a situation we see a lot, especially in the aesthetic zone.
Mm-hmm. That's a very interesting question. That's something that it cost me a lot of time, a lot of cases, a lot of documentation to understand nowadays how to achieve it. Because, you know, most of the cases that we have a single implant, like I said, we have the interproximal bone peak. And if we set up the contact point at the correct level, even if we don't, sometimes we don't need to graft soft tissue, we will wait and the papilla will appear. But it can happen that sometimes the interproximal bone peak of that tooth is already gone. And sometimes we are fooled by this. I'm dealing with single implant, so I have the tooth. So probably I will open the contact point at this level and I will have the papilla, and I will not have the papilla. And sometimes I graft, but I graft incorrectly, and still I don't get the papilla. Let me share the screen. I told you I have a backup slide for
We
some
have some
questions.
cases
That's
for
the
these
case.
questions. This is
That's
the
the
question. In
case.
the meantime,
Yeah,
let me say hello to Milan Vukotic, who is joining us from Serbia, and everyone who joined later. We are talking to Paulo Carvalho from Porto in Portugal, where it's beautiful weather, as you can see. It's nice and sunny. We're talking about how to deal with soft tissue defects, and we've ended up on those cases where we have an existing implant with a soft tissue defect. Might be dehiscence or shine through, and we're going to talk about what we can do. In this case, any thoughts on the surgical papilla regeneration? Show me, Paulo.
In this case, for example, we know these measures from some studies. In this case, the study from Garber and Salama about the distance, the mean distance where it is expected to have papilla between implant and tooth, and sometimes when we have already the interproximal bone peak, like in this case, the interproximal bone peak from between 12 and 11 is already gone. So I can show you how the case ended up without the papilla, with a back triangle, and see that I already did a composite on distal of 11 to try to block a little bit the black triangle, but still not enough. And you can see that in this case, I did soft tissue augmentation, or buccally, occlusally, and palatally, trying, because I saw the absence of the interproximal bone peak, and I tried to augment the soft tissue and try to compensate the loss of the interproximal bone peak, just like I showed in the multiple cases, creating excess of soft tissue and then try to compress. But the problem is that a lot of times, and this is an error from the past that I'm not doing nowadays, you can see that I ended with surgery. You can see on the right bottom, you can see the end of the surgery. I tried to close the flaps, to advance the flaps and close it around the provisional, but the provisional was occupying too much space and it left my papilla open. So it doesn't matter if the graft is underneath, because it is not fully submerged. It will probably go under necrosis, and still I ended up with what you see in the final restoration, which is a black triangle. So I quickly understood that it was really important to first create the excess of tissue, and then after graft maturation, after 3 months at least, then start to reshape it, but only after having the excess of tissue. So here you see the completely opposite thinking. You have a missing papilla, the distal papilla, because of the missing interproximal bone peak as well. It is a very narrow space and very narrow mesodistal space. So in this case, I graft occlusally after implant placement, even though I can make a provisional because the implant is stable. I prefer to submerge and delay. And then after this excess of tissue, I will then start to reshape this excess of tissue, and the papilla is already there because it was already there from the beginning because of my advancement of the tissues with the grafts underneath. And then I have the distal papilla, which I had not at the beginning. And then you can make the definitive crown matching this soft tissue. So it's a very interesting question, because for a long time I was neglecting single tooth restorations on implants because of counting with that interproximal bone peak that sometimes it's not already there, even though I have a tooth assigned.
Exactly. Now, Paulo, I'm taking notes. First of all, congratulations again on your honesty, because you're now officially also an expert on stage sharing an unsuccessful case. A lot of complaints is always, everybody's always showing when it went well. Beautiful smiles. So thanks for sharing that as well. Just very quickly, you said, although I could have gone for directly, I chose to submerge. To me, it's not exactly clear why you chose to do that. Is that because of your experience that you now know that you will get a better papilla, or why did you decide to do that?
Yes, because if in that narrow space, if I try to do an immediate provisional, in that case, the space occupied by the provisional will probably not allow me to fully close the flaps and get the papilla at the right position. And so I needed to close and create that excess of tissue. After the excess of tissue, then I can push the tissue for the correct emergence profile.
So that was very related to the narrowness of this
yes.
case.
Yes.
In this case, exactly.
It can be like I said at the beginning. A surgeon might be with the prosthodontist at that moment and realize even after trying to do the provisional with the provisional already in place, I cannot fully close the space of the papilla, so let's take out the provisional and let's close it. So some options have to be made during surgery against what was planned before in order to accomplish the best outcome in the final restoration.
And then we reiterate the most important takeaway from this Just Ask Tonight. If you joined us later,
sure.
The perio and the prostho should always work together, whether it's in one person, like with Paulo, or whether it's the two professionals together, even in surgery. That is shown perfectly again. Now, Edwin Ruales Carrera first says, shout out, amazing topic, amazing guest. So that one is for you,
Good friend of mine.
Yeah, I figured that. But still, Edwin submitted a great question. He says, Dear Paulo, what about the use of soft tissue substitutes in order to gain volume or better contours? What kind of cases would benefit from these type of options?
Well, good question, and good to talk about that, because of course that might be some misknowledge around that topic right away because of all the marketing that we have nowadays on that topic. I see some space in our clinical practice for soft tissue substitutes, but not around implants, because around implants we need real volume, real dense soft tissues, and it will be difficult to achieve with the soft tissue substitutes. I can see them being applied around teeth for teeth recessions, for when we have root recession, root exposure, and we have to cover the recessions around teeth. And even in those situations, it has to be in cases where we still have some width of keratinized tissue to cover the recession, because in those cases, the soft tissue substitute will rely on that initially remaining keratinized tissue, and then we will have some thickness of the biotype, which is what we want. But in those situations, we are not talking about ridge augmentation. We are not talking about giving volume to the ridge, because the ridge has not a defect. The root is already there. We just need to thicken a little bit the biotype and advance the tissues to cover the recession around the teeth. So in those cases, the soft tissue substitutes might be effective, but around implants, to really augment the ridge contour, we need real volume, and we know that those soft tissue substitutes tend to resorb during time.
Exactly, because I was going to ask on what aspects are they failing then? Is that primary? Is that the stability? It's not primary, but is it stability, or you say they're receding?
Yeah, it's because of course I can only talk about my experience. I can only talk about also some literature that I've been studying, and I think we are still lacking a lot of literature on this topic, and especially a lot of literature with real long follow-up terms, because follow-up is what we really like. And when I see it from these two perspectives, I see that a lot of times there is a relapse between the final of the surgery in the final volume and the healing periods subsequently. And in the soft tissue, the autogenous soft tissue surgeries, we see quite the opposite, which is the tissues are always getting better in time. A lot of times, most of the cases I graft soft tissue, dense soft tissue from the palate, the posterior palate or from the tuberosity, I see it in the follow-up years. Most of them are advancing coronally in creating still excess of tissue that sometimes I need to reshape,
the
sometimes
tissue is
not.
Literally alive.
Yes, it's completely alive. It's on motion. It's creeping all the time, which might be a problem if the patient complains that the tooth is now shorter than at the beginning. But I can quickly solve that, the lack of tissue will be a problem that it will require from us for the surgeries.
Exactly. So we're still exploring a bit the situation when you're dealing with implants and soft tissue defects. Is there a way where we can kind of predict or quickly assess whether it's worth trying to save this implant or when we know it's too far or too late? What are the indicators we need to be looking for?
Yes. First, in the aesthetic area, I will only cope with implants I can fully cover and match a perfect pink and white balance as the adjacent teeth. Because of course, in the posterior zone, for example, sometimes we might allow some compromise, some less volume than ideal, or a little bit of exposure of metal, but still have the implants functioning with health and function at the same time, but not the same aesthetics. But on the aesthetic zone, the patient will only be able to cope with almost a perfect situation, almost like appearing with a natural tooth. So if I'm able by the interproximal attachment to do so, I will do it. But probably the key points to look at is try to understand if the head of the implant, the platform of the implant, is inside the bony contour. It means that an implant can be too buccally placed, but still inside the buccal contour of the adjacent teeth. Those cases probably we will be able to successfully cover the recession of the implant and create enough soft tissue that will be stable with time. But if the implant is that buccally, that the head of the implant is outside the bony contour, probably we will not be able to completely cover the implant. And even though after the surgery it is covered, in the healing time, it will probably face some recession and some relapse of the tissue. It will not be good for the patient. So I will say that we can see a case. Sorry, and let me get the slide for you.
Yeah, well, while you look for that, let me remind our audience that we are live, at least if you're watching this on May 3rd, World Osseointegration Day, the first ever, if you've never heard about that. And we have about 15 minutes left. So please reflect on what you've heard so far, how that applies to your situation, and whether that triggers any follow-up questions, whether it's clarifying, whether it's challenging, or whether it's something you're just curious about, because we have 15 more minutes to go, and I'm here just to relay your questions on your behalf. In the meantime, Paulo, you've shared your screen and we see a next case.
Yes.
What are we looking at?
We are looking at a completely functioning implant at 22, but of course with recession of the margin, with some grayish tissue appearing, and you can see how the implant is buccally placed. So when you see the implant without any buccal bone at all until the apex of the implant, you might realize right away it is too buccal. We have to extract the implant and start all over again. But the truth is that the implant was not that buccal. The hole of the screw was appearing on the sides edge, but the problem is that we needed probably at the beginning to perform bone augmentation at the same moment of the implant, or the implant should have been a narrower one. But what I realized, it was inside the bony contour of the adjacent teeth. So I opted to do, and I'll go very quickly without showing the step by step. I did some crown lengthening on the adjacent teeth, and did some soft tissue grafting. You can see here a very thin soft tissue graft, but although it is thin, it is a very thick one with the potential to grow in time, something that will not happen with the soft tissue substitutes. And I can perfectly put it in place around the first 3 to 4 millimeters of the implant in the transition zone. And I submerged the implant temporarily. So we advanced the tissues. I sutured it on the palatal side, and the patient was without the screw retain crown. And only after 3 months, you can see already how the color of the tissues changed completely to a very whitish one. completely the opposite, only 1 millimeter of soft tissue. And then after some veneer preparation on the neighboring teeth, you can see how here it was the moment where we did the veneers first on the neighboring teeth. We maintained the provisional on the implant site where it was still maturating. And here there was a breakage, the provisional broke, and you can see how the tissue was in excess. I did some peeling of that tissue because of the texture, and you can see now the beautiful soft tissue around the implant with no buccal bone at all. And then finish the case by doing the delayed crown on the implant. And I don't expect this huge soft tissue to be having recession with time. You can see the before and after, and the different margins, not only bringing the margin of the implant coronally, but also putting the margin of the teeth a little bit apically to create some harmony. And of course, when we see it from the patient's face, the patient's point of view, it's quite astonishing what we can do only with one surgery, one soft tissue graft. And of course, once again, the interaction between the perio and the prostho, and in doing multidisciplinary cases, we are able to get harmony between the different teeth in the front.
Exactly. Beautiful smile, a great success case. So here we are again. But you have somewhat confused me though, Paulo. What is the lesson here? Because first you say you just look at the bony contour and whether it's whether it's outside, and then you show me a case where it was outside, and you said, well, I was actually able to augment with soft tissue anyway. So what is the key lesson here?
No, because even though I can show you here, I will share again in the. This is the you are seeing my screen, right?
Yeah.
So you can see that this in an occlusal view, this is the CBCT scan from the implant. You can see that it is a little bit too buccal, but you can see that the bony contour of the adjacent teeth are even more buccally. So at the level of this implant, the bone is really resorbed. But the original bone contour of these sites, when the tooth was still there. Sorry, the contour was this one. So only when the implant is completely outside the original bone contour is that when we know we are struggling completely against the biology, and even though we can cover it at the beginning, it will recede with time.
Exactly. Well, that's clear again. So it's important to look at the original bony contour.
Yes.
If it's out of line with that one, no chance.
But I can make you confused again if you want.
No, well, only if it helps and if it teaches us to better understand what we can do. Yeah, show me.
Yeah, it helps because sometimes, like in this case, I was completely prepared to extract this exposed implant because it was too buccal in a very young woman. But the problem is that sometimes we can face this, which is when we look at the CBCT scan, although it is a little
Paulo,
too buccal.
If you want us to look at the scan, you need to zoom it in again, because now it's really small.
Okay.
So, yeah.
Here.
Yeah, but you either like.
Are you seeing it?
Yeah, I'm seeing it, but very small. So you either need to zoom in again, like you just did, or you put it in presentation mode, because otherwise it's tiny.
Okay, let me see like this. Better?
Yes. Yeah.
Okay, better. So you can see that, especially at the 12 implant on 12, we have no bone buccally and no bone palatally. So even though because of the landmark, I wanted to probably extract the implant. If I extracted the implant, I was not sure I will have enough bone to replace the implant comfortably. I will have again to do a vertical augmentation, but I was not sure if I will have the interproximal bone peaks to do it. And I chose in this case to cover the implant. It was needed 2 surgeries, one coronal advanced flap to cover, to thicken the soft tissue. On the 22, we are seeing now it is a tissue level implant, which is very difficult to manage the emergence profile and cover the implant as well. And then in the second surgery, we could do a tunneling approach to, again, augment furthermore the margin coronally. And after the second surgery, only with soft tissue, we were able to fully cover both implants and then do the prosthetics with veneers on the neighboring teeth as well, to get the proper harmony of the smile of this young patient. And you can see how the margins evolve with time. And you can also see how this is going after 2 years of follow-up. But of course, again, this might be controversial because if we think of it, the head of the implant is a little bit too outside the bony contour. But again, we have to think case by case, specifically, because sometimes we might have to think about other other things that might condition our option. And in this case, once again, I prefer not to go through bone augmentations that was not predictable in my hands.
And once again, help me understand again why. So you say that the implant was slightly outside of the bony contour, yet I still decided to go for soft tissue augmentation. And that is why specifically in this case? Because
when we go to the beginning, the CBCT scan, we can see that we have no bone at all outside buccal to the bone and palatal to the bone. So it was completely trapped in the interproximal bone. So if we removed it, probably we will have 0 bone in height to place a new implant. So it will be even more difficult to place a new implant. So I try
now I understand why you say you confuse me even more, because now we have an implant outside of the bony contour. However, extracting is not an option because there's no bone to place a new one. That's what you say.
Yes.
Clear. Well, very clear.
I really managed to confuse you. I told you so.
Well, I'm just being here as a representative of our global and international audience. I already saw people, Anita is joining from Guatemala, Melissa is joining as an Ecuadorian from the Netherlands as well. So I hope, dear audience, that I'm relaying that you're having the same questions and thoughts as I have. And if not, this is your final moment to submit any questions or comments to Paulo, because we're nearing the end.
You are doing an amazing job, Gerrit.
Well, I'm trying. I'm really at the service of the global implantology community. Now, Paulo, we covered several steps. We talked about the importance of combining the periodontic and prosthodontic expertise all the way through the process. Now, I'm remembering several Just Ask Backs that we started to talk about human factors, right? Of course, it's important to get the science right, to get the surgery right, but in the end, we are also people and humans. So in these last few minutes, I would like to talk to you a little bit about the arguments that people walking away from this Just Ask need to bring into their clinic to actually make this happen, right? Because the first thing they're going to get is, well, no, that's not how we organize things. That is double the cost. That is double the hours. So how do people start to implement bringing together these expertise in the protocol?
Well, you touched the human part, and it's something that probably with the experience and with time, I tend to pay more and more attention to it, because of course, at the beginning, we are fully focused on what books say, or on what was the last technique I learned, what was the last thing I saw in a congress, and I want to apply it right away. And I think that what's experience, knowledge, all the study, all the literature I've been putting all together, what it all together brought me to my clinical practice is exactly that, is that being able to play different instruments, being able to apply different techniques, being able to apply different solutions for different patients. Because one thing for sure I realize in the current times is that patients want the best results in the less time possible, or at least in the less interventions. I see my patients coping very well with me and waiting a lot of times if they are with very beautiful, stable provisionals. And then they can wait for sometimes a year of a complex case shaping emergence profiles. What they lose patients very quickly is when we have to do multiple surgeries. Then is when I see that people struggle to say yes. And I can understand them. The more complex we do it, the more they suffer, not only during the surgery, but also in the post-op. People's lives are more and more demanding. They have more difficult jobs. They have less availability to cope with the difficult post-ops because they have their jobs. They can be away from the jobs. They can be away from the families. And a lot of times I face myself with that human factor, because even though I say to some patients, the best option for you will be to this step and this step and this step and this step. And sometimes they go with, okay, but I have just this availability of money or time or patience or suffering to cope with. And that's why it's obvious that I chose some cases that I wanted to really share something out of the box, that we could do the most with less things. And experience and time made me mature in that point of view, in which I realized that sometimes the simpler treatment is the most effective one. And sometimes even doing awesome things I learned from awesome people, sometimes it's not always best for all patients. And every time I spend more time studying the case, there's a phrase I say a lot to my students, is that the more complex a case seems, try to take more and more time to study the case. When you in the planning of the case and you get that feeling of, okay, I know what to do it. Okay, rethink again, because probably there is something you miss out, probably there is something that you didn't really face the risk. And then when you rethink the case, you'll see that, okay, I have a better solution. I can avoid this, and I can step this problem. And I face myself in doing simpler treatments much more effective than more complex ones.
Wow, very inspirational. I hope that message goes viral over the
Great.
internet. Thank you very much, Paulo. And with that, we've come to the final minutes of our EAO Just Ask of the month May 2021. Don't leave yet, because there's a few important things that you need to do. First of all, if you're watching this, whether now live with us or in recording, you are on the EAO channel, which is the most interesting place on YouTube you can find. There's a ton of these EAO Just Asked, 16 previous editions. There's a load of videos, clinical videos, conference videos, anything to learn. So make sure you hit the subscribe button right now. You'll be the first to know when a new video comes out. And if you know anybody, specifically if you joined us later, obviously in a few minutes you can go back to the start and watch this entire video from the start. But if you know anyone who might find this video interesting or might benefit from the tips that Paulo Carvalho has been sharing with us over the last 75 minutes, make sure you copy that link and forward it to them through any means at your disposal. With that, on behalf of our viewers tonight, Paulo, and on behalf of the EAO and everyone involved in producing these EAO Just Ask, thank you very much for your time and effort today, for being with us.
Guys.
It was a great honor, and it was very, very educational. I learned a lot tonight, and hopefully we read soon in the chat that our viewers learned a lot as well. And if you enjoy these EAO Just Ask, note that we're here most of the times first Monday of the month. Next Monday of next month is June the 5th. We'll be here again, same place, same time, 8:30 Central European Summertime, with the next leading expert and allowing you to ask any questions. With that, we've come to the end. Paulo, thank you very much.
I thank you.
And to all our viewers, I say, see you next time.